So to talk about low back pain, I'd like to provide you all an understanding of the spine, how degeneration, old age can degenerate the spine. Okay. So if we first look at this picture, we can see that there are blood vessels, there are artery that supplies to your vertebral body. And then if we look at the green color thing that we call it cartilaginous end plate, your artery or blood vessels pretty much supplies the nutrient to this end plate first, which is the green color thing. And then once it reaches the end plate, then the nutrients will then be transferred to the disc via diffusion. What I mean is that your spine needs to be loaded, needs to have some compressive force in order for your disc to be healthy, in order for your disc to receive nutrients. And the end plates are quite porous, so meaning they allow the materials to be transferred towards the disc. So from here you can look at this picture where there's blood vessels that's supplying the end plate, and from the end plate nutrition like oxygen, fluid then flow into the disc. However, as we age, the end plate starts to calcify, meaning the holes start to fill up, and then there will be a lack of nutrients that's being supplied to the disc. And another thing can happen is that the blood vessels or the artery that supplies nutrients to the end plate are somehow affected. So if there's anything that constrict or narrow your blood vessels, it is going to affect the health of the end plate, which is then going to affect your disc. Okay? So according to this journal, the lumbar degenerative disease, let's look at the etiology of degeneration of this disease. Okay, it says that degenerative disc disease is a complex interplay of structural, genetic, environmental, trauma, and aging. So if there is non-traumatic degeneration, it usually starts with progressive decrease in these nutrient supplies that changes the matrix composition as part of the aging process. So what happens is that there is a lowering of pH level and oxygen concentration. And this leads to the calcification of the end plates. And if there is an accumulation of microtrauma to the spine over time, it would spread the mechanical damage, manifesting as the annular fissure, meaning tearing of the disc, or damage to the nucleus or damage to the disc. So in terms of the environment and psychosocial factors, if you are someone who smoke, if you are obese, if you have diabetes, or if you have high cholesterol, all these are going to affect your blood vessels. It's going to cause narrowing and restriction of your blood vessels. And because you have this narrowing of your blood vessels, as I said earlier, the supply to your end plates will be affected, and then the health of your disc would be affected. Okay, so if you have degenerative spine, it is not just due to aging, it is due to how you live your life. Do you smoke? Do you have high cholesterol? Are you overweight? Do you have diabetes? Do you have high blood pressure? All these lifestyle factors is going to determine how healthy your disc and spine is. And if you look at the exercise part, physical exercise help IVD, meaning intervertebral disc cell proliferation. Okay, so if you have a high volume of low repetition and frequency in exercise, you can help to increase the size of the disc, helps it to grow. So if you are physically inactive, your disc and your spine is not going to be healthy. Now if we look at this journal called the running exercise strengthen the intervertebral disc. Okay, here we show that chronic running exercise in men and women is associated with better intervertebral disc composition in terms of hydration and the contents, and with the hypertrophy of the disc. And they found that physical activity, that acceleration at fast walking and slow running, but not high impact tasks, lower intensity walking, correlates with better disc. Okay, so these findings might represent the first evidence in human that exercise can be beneficial for your disc health. So in this journal, the main finding is that long distance runner and joggers show better hydration of the disc compared to a non-athletic individuals. And that the hypertrophy of the disc can well be an adaptation to habitual loading in runners, similar to resistance training. And it also says that high impact loading is considered to be detrimental to your disc and the end plate, and that the fast walking or slow running may provide the strongest anabolic, meaning muscle building, meaning building stimulus for adaptation of the disc in the humans. So let me recap. I've mentioned that the disc need to be loaded, and with appropriate loading, there is diffusion nutrients flowing through the disc. Okay. So in the wider population, it is lower lumbar discs that they are most commonly affected by degeneration. Furthermore, repetitive loading of the spine is considered to be a contributory factor to the development of disc degeneration. So in contrast, the long-distance runners and joggers show evidence of better disc hydration and glycosaminoglycan content in the lower lumbar spine than those that did not perform sport. So what this paper tells us is that if you have low back pain, the first line of treatment is for you to start exercising. And when I say exercising, I'm saying just walking, slow walk, and any movement that you feel fine, that you can do it. Mobility, low general exercise. It doesn't matter what sort of exercise that you do, as long as you are moving, you are applying some compressive force or loading to the spine, that is going to supply nutrition to the disc, as well as removing the metabolites or removing toxins, if you want to call it, from the disc. So there is a fluid exchange, and then that will help you with your back pain. Now that I've covered the etiology of degeneration of the spine, and you have an understanding that lifestyle factor plays an important role in your spine health, we are now going to look at the clinical guidelines on how to manage low back pain. So from this latest journal, there is released on November 2021, by the Journal of Orthopedic and Sports Physical Therapy. First thing first, the cause of ongoing low back pain cannot be seen on MRI or X-ray, which can be very frustrating. And the pain is still very real and can have a real impact on a person's life. So the recommendation of the guideline for back pain is exercise, manual therapy, and education. Okay, and when we talk about manual therapy are like massage, joint mobilization, or soft tissue mobilization. The aim is to relieve stiffness and get your spine moving better. It doesn't say that the aim of manual therapy is to get you out of pain. The aim is to relieve stiffness so that you can get your spine moving. Okay? And in terms of exercise, right, we can do aquatic exercise, aerobic exercise, like walking, cycling, swimming, dancing, strength training exercise with weight, bands, or body weights. So basically, any general exercise, as long as you're moving your body, is going to bring you good. It doesn't matter what exercise you do, as long as it's not a high impact exercise. Okay. Now, when we look at this journal produced by the Lancet is like a very reputable journal. It says that for nearly all people with low back pain, right, it is not possible to identify a specific nociceptive cause, meaning a specific injury that causes pain. Okay, only a small proportion of people have a well understood pathological cause like fracture, cancer, or infection. So in my understanding, 90+% of people who have low back pain, their back pain are considered as non-specific low back pain because there isn't a structure or pathoanatomical diagnosis that can confirm that your back pain is related to this. So we term it as non-specific low back pain. Or we can use the term called sprained low back. The reason why we use this non-specific low back pain or sprained low back rather than degeneration of your disc or wear and tear or protrusion is because by using this term non-specific and sprained low back, you are less likely to seek MRI or X-ray. And you believe that because it is a sprain, it is a non-specific one, that your chance of recovery is much more higher compared to me saying that, oh, you have a disc protrusion. And that is going to stay in your mind for a long, long time. And I'm going to tell you that your protrusion of the disc is going to be reabsorbed into your spine. I'll show you some articles later within 1 year or so. But the people that I see always tells me 5 years, 6 years, or 10 years down the road that they still think that they have a protruded disc. And this is it's just a nocebo effect. It's contributing to your psychological and protective behavior of your back, and it's not going to help you to recover because you have the thought that you have a disc that's being protruded. Flexion is not helpful, it can aggravate the problem, and then you need to stiffen your spine to protect, to brace your core. All those are no. And that 1%, less than 1% of low back pain are due to like cancer, fracture, or infection. And here it says that rarely can a specific cause of low back pain be identified. Thus, most low back pain is termed non-specific. And when we osteopath or chiropractor trying to click your spine is because we think that there is a facet joint dysfunction, meaning the joint between the spine, the vertebrae body, that somehow is locked, and that if we were to able to crack the spine, then we are able to unlock this facet joint and you're supposed to feel much better. Well, look at this study. Facet joint. It says that injecting the facet joints with local anesthetic can cause temporary relief of pain. However, the Framingham Heart Studies, which is it's just a very good study, did not find an association between radiological osteoarthritis of facet joints and presence of low back pain. Okay? No association between degeneration of the facet joint with presence of low back pain. And clinical identification of individuals whose facet joints are contributing to their pain is not possible. Okay? So for those who think that cracking helps, maybe it helps in another way. So what is low back pain? Low back pain is a symptom, not a disease. There are some serious causes of persistent low back pain, like fracture, infection, or inflammatory disorder like spondyloarthritis, that requires identification and specific management targeting the cause. But again, this accounts for a very small proportion of cases. Like I said, study says it's less than 1%, okay? Now in the second series of the journal, it says that the recommendations to manage low back pain includes the use of biopsychosocial framework model, and it includes non-pharmacological treatments, meaning no drugs to start off with, and that the first line is education and to support self-management and resumption of normal activities and exercise, as well as psychological programs for those with persistent symptoms. Psychological programs are helpful for those who have fear, anxiety, depression, belief about their back pain is very poor, self-efficacy is very poor. So for people who have chronic low back pain, as I've mentioned, it's a multifactorial thing. Psychological, like cognitive behavior therapy or acceptance commitment therapy, is able to help you with your psychological factors. As I say, it's resources and demand. If you can help your psychological stuff, you increase a little bit of your resources, okay? And if we look at the table here, the evidence of prevention strategy for low back pain, it is effective when you combine exercise and education, okay? Shoe insoles, which a lot of my patients are looking at, ineffective. And ergonomics intervention at workplace, also ineffective. The most effective is to exercise, move your body, and have some education about what low back pain is, okay? Okay, here there's an interesting thing says that paracetamol was once recommended as the first line for low back pain. However, evidence of absence of effectiveness in acute low back pain and potential harm has led to recommendation against its use. So right now, if you want to take medication, go for non-steroidal anti-inflammatory drugs. NSAIDs, they are like your ibuprofen, Nurofen, Celebrex, meloxicam, is it? Yeah. So if you look at this, this is an overview of interventions endorsed for non-specific low back pain, which meaning the 90% of the low back pain. It's based on evidence, clinical practice guideline from the UK, US, and Denmark. So for people with low back pain or persistent low back pain, the first line is always to remain active, exercise, walk, general fitness whatsoever. It's education, learning about what low back pain is, how degeneration in the spine happens, and also the basically natural history of the spine, which is 6 weeks. Usually it takes people 6 weeks to be out of pain, and it's self-limiting. Okay, even without doing anything, your back pain most likely will go away within 6 weeks. And that's what the study says. Okay, and that exercise therapy should be the first line. You can use some psychological treatment if you have chronic persistent low back pain, and you can go for like osteopathy, massage, acupuncture, yoga, or mindfulness-based stress reduction. However, they are all second line, including painkillers. So the main thing to take back is that you need to remain active, you need to be educated, and you need to move. And psychological treatment can help you if you have ongoing low back pain. Now to summarize, this flow chart is from the NICE guideline, meaning from the UK, the NICE meaning National Institute of Health for Excellence, something like that. This is the flow chart for managing low back pain and sciatica. So for anyone who have low back pain with or without sciatica, meaning radiation down the back of your legs, first thing first is you need to be educated and you need to have advice to support self-management. And then exercise, manual therapy, or some painkillers, or some psychological treatment is the first line of treatment. And if you can look at this, do not offer acupuncture and electrotherapy, traction, like the traction table, right? Or orthotics like the insoles, or any belts that supports the back, or any spinal injection or spinal fusion. Interesting, right?